This is the first of three presentations illustrating the Stop Thalassemia project by the Cure to Children Foundation. In the first one, there will be a brief overview of bone marrow transplantation, the only consolidated way to cure thalassemia. In the second, there will be an overview of the experience of the Cure to Children Foundation on over 100 bone marrow transplants performed directly in developing countries. And on the third, the prospects of the use of bone marrow transplantation to cure most patients with thalassemia. Part 1. Introduction to bone marrow transplantation. In this presentation, there will be an overview of bone marrow and stem cell transplantation. We will briefly discuss bone marrow versus peripheral blood versus cord blood as sources of transplantable hematopoietic stem cells, infection control issues, and late effects. So what do we mean by stem cell? Essentially, a stem cell is a cell that is capable of self-renewal and to generate specialized cells. These are either embryonal or adult stem cells. For clinical transplantation, we only use adult stem cells, and these are present in bone marrow, in peripheral blood, and in cord blood. Hemopoiesis is the process by which blood cells are formed, derived from stem cells in the bone marrow mostly, and these can either be so-called myeloid cells, red cells, platelets, and the different types of white cells, but also lymphoid cells that are the cells of the specialized immune system. So B cells or B lymphocytes that produce antibodies, and T cells or T lymphocytes that have T cell receptors. Bone marrow or hematopoietic stem cell transplantation is the infusion in a receptive host, so a host that is immune suppressed to prevent rejection, of an amount of viable stem cells and often other cell types like B or T cells, lymphocytes, which is sufficient to engraft, sustain long-term hematopoiesis, and substitute the immune system. Hematopoietic stem cell transplantation can either be allogeneic or autologous. Autologous is the use of the patient's own stem cells to regenerate the bone marrow after very high doses of chemotherapy, which for some malignancies, for example leukemias or lymphomas, can increase cure rates, but on the other hand can cause permanent damage to the bone marrow that needs to be regenerated with autologous stem cells. Allogeneic transplantation is between two non-identical individuals and is used to cure acquired or congenital severe disorders of blood-forming and immune system, typically thalassemia, sickle cell disease, or aplastic anemia, or severe immunodeficiencies, or high-risk malignancies. This difference between donor and host can translate into an immune reaction against malignant cells, which is called graft versus malignancy effect. So as mentioned, in allogeneic transplantation, this difference between donor and recipient can result in an immune reaction like in any other form of organ or tissue transplantation, so that the residual T cells of the host, of the patient, can recognize as foreign the bone marrow of the donor, mount an immune reaction, and potentially cause a rejection. On the other hand, there is another immune reaction in the opposite direction, which is typically of bone marrow transplantation, in which also immune cells are infused together with the bone marrow, which is mediated by donors T cells that recognize as foreign normal host, normal patient tissues, and mount an immune reaction which can cause graft versus host disease. As I mentioned, this can also be targeting malignant cells in a process that is called graft versus malignancy effect, and that is used for the cure of malignancy through allogeneic bone marrow transplantation. There are essentially three sources of transplantable hematopoietic stem cell. One is bone marrow and peripheral blood or cord blood. There are no major differences, though, in terms of stem cell quality or potential for long-term engraftment among these stem cell sources. Bone marrow transplantation itself is composed of several phases. There is a preparation phase in which the patient is treated to eliminate diseased bone marrow and also to decrease his potential to reject the bone marrow. So he's given immune suppression. So this therapy in the context of malignancy also can kill malignant cells. Then in allogeneic transplantation, the bone marrow is collected with a relatively simple procedure from the donor. Is by multiple punctures of the iliac bones that is then collected in a bag and reinfused the same day to the patient. Not much differently from a transfusion. Stem cells of the donor infused intravenously spontaneously home to the bone marrow of the patient. This is followed by an engraftment phase in which blood cells derived from the hematopoietic stem cells of the donor appear in peripheral blood and can be detected by a blood count, and these are some neutrophils, platelets, and red cells. In thalassemia, for example, on average, after 2 to 4 weeks from transplantation, the last transfusion is given, so the patient becomes transfusion independent. There is a longer immune recovery phase in which the specialized recognition systems of B lymphocytes and T lymphocytes, which has a very wide repertoire in order to recognize different infectious disease agents, is slowly reconstituted, and this can take anywhere between 6 months and a year or even more depending on complications. So, for example, patients after bone marrow transplantations are revaccinated on average after 1 year. The preferred allogeneic donor is a so-called matched related donor, that is to say a brother or sister, which is HLA matched, and so it's considered a histocompatible donor. But there is a 25% that any given sibling couple will be compatible. So depending on family size, most patients that are candidate to bone marrow transplantation may need alternative donors, and these are either unrelated donors, unrelated cord blood from blood banks, or partially matched related donors. So by partially matched related donor, we mean a family member which is not 100% compatible, generally is 50% compatible, is also called haploidentical donor. And the typical example would be for a child, his mother or his father. And this is probably emerging as the most feasible, probably even safest options, particularly in developing countries. Complications and late effects, infectious complications are the most concerning in general, but there are increasing effective means to prevent these infectious complications as well as to do early diagnosis and treatment. So it is becoming less and less frequent to have infectious related mortality from bone marrow transplantation. This is the major non-infectious complication, which is graft versus host disease. It can affect the skin, but also the gut and the liver. In terms of late effects, infertility is probably the most important one. Roughly half of the patients with current Preparative regimens can have fertility problems. This in female can be associated with delayed puberty but can be treated. Impaired growth and development, second malignancies, and intellectual impairment are generally not a problem, especially for thalassemia where total body radiation is not used and patients have not been exposed to any central nervous system directed therapy prior to transplant. Are there additional concerns in low resource settings for other infectious problems? Actually, there is no evidence that this is the case. So just because a transplant is done in a low resource setting doesn't mean that there is increased infectious risk. Hospital infection control. Many units have complicated and expensive air filtration system. However, particularly for low-risk transplantation, there is really no evidence that this has any impact on outcomes based on well-designed clinical trials. Probably more important than fancy air control system is proper hand washing and disinfection that should be readily available throughout the bone marrow transplant unit, easy cleanable rooms to be kept as dry as possible, and have a surveillance system for monitoring of room surfaces and air sampling. But most critical to bone marrow transplant success is the proper indication, so offering bone marrow transplantation to the right patients, prepare these patients well, and this is particularly feasible for thalassemia, which is a chronic disorder and allows enough time to have the patient in the best possible shape. Nursing team is one of the most important assets for the transplant unit, both in terms of proper drug administration and infectious control. Family support is critical to the success of transplantation because families often, especially in low resource settings, may go back to challenging situation and they need to be followed and supported, and of course quality management. Thank you for watching this video, and I hope you will support the Stop Thalassemia campaign by the True to Children Foundation.